Welcome. I wanted to take a little bit of time here and go over the CMS HCC Risk Adjustment program. Of course, this is a fairly complex issue that just about any of us that see Medicare patients, or actually any patients, commercial, whatever, need to understand, because it's critical, especially with all the new value-based contracts, MSSP, all the Medicare Advantage plans. All of us will be judged based on our ability to make sure we accurately record the health burden of the population we take care of. Otherwise, we won't get credit for some of the sicker patients that we may take care of that use up a lot of resources. So I want to start with a couple definitions here: risk adjustment factor, risk score, HCC, and then the RX HCC. So the risk adjustment factor, CMS uses this to account for the differences in the beneficiary level risk factors that can affect the quality outcomes or medical costs regardless of the care provided. So the goal is to enable more accurate comparisons across networks that treat beneficiaries of varying clinical complexity, because some networks may have more healthy patients than others, and you can't put everybody into the same pot. So you have to be able to adjust for that. So it removes the differences in health and other risk factors that impacts measured outcomes but are not under the TIN or the provider's control. So the purpose is that CMS can pay the Medicare Advantage plans for the risk of the beneficiaries they enroll instead of calculating an average amount. How does that work? The MA plans receive a payment for each covered member from CMS. Risk adjustment is used to adjust the plan payments to ensure that they're accurate and adequate to provide the service and cover the benefits. The payment is driven by the risk score, which is based on the member's predicted health status and demographic characteristics. So what do we end up with is the Medicare risk-adjusted HCC, or hierarchical condition category model. The risk score, critical to understand that. Of course, it is based on two factors. Each member, no matter if they have no medical conditions, don't take any medicine, every person in Medicare has a risk score because they get a demographic risk score. So it's based on their age, their sex, and whether or not they're institutionalized or Medicare or Medicaid and Medicare eligible. And then to that score is added their health status, the conditions like CHF, diabetes, and other things that risk score. So with risk adjustment, we have the higher risk score that represents members with a greater than average burden of illness. The lower risk score, though, is not necessarily that you have a healthier population. Sometimes it's because you have inadequate or incomplete chart documentation, or you haven't coded the diagnosis correctly. Just what I said a couple minutes ago, this goes to show you that every patient, so a 65 to 69-year-old female, has a risk-adjusted score of 0.312, whether or not they have any other medical conditions. This is added to those medical conditions, so they start out with a minimum of a 0.312, and a male in the same age group of 0.30, and then as you can see, if they have Medicaid, they get a little bit higher risk score of 0.492, and if they're institutionalized, 1.269. The critical thing to understand is these hierarchical condition categories. These are groups of clinically related diagnoses, the ICD-10s, with similar cost implications. So only the diagnoses, though, that match to one of these categories are used in the risk calculation. You have almost 70,000 ICD-10 codes. Only 8,800 of them map to these risk score categories. Of that, you have 25 condition categories and 79 of these actually HCCs. That means that, and let me show you the next slide here, that basically what we're looking at here, and you're going to see there's 189, even though I just said there's 79, you're going to see that each disease state kind of has multiple HCCs because it's a hierarchical condition category. So metastatic cancer, which is HCC 8, actually will trump any of the 9, 10, 11, or 12 cancer diagnoses. Same thing with diabetes here, which is a 17, 18, and 19. So the lower the number here, 17 will always trump 18, 18 will always trump 19. And I'll explain what that means here in a second. So let's look a little bit more at that in detail. The sources for these condition categories come from physician offices, hospital, inpatient, and outpatient. It's a prospective model. That's critical. That means the diagnosis from this year is what's used to predict the payment for next year. So you have to be very accurate, but if you have a lot of new diseases this year, you're not getting credit for them until next year. There's some interactions, which like CHF and diabetes will give you an additional risk score. Of course, we already talked about the demographic factors, and this gives us our disease hierarchy. Each January, the risk score is reset, and we'll talk about that a little later. So these hierarchies, how do they work? As I said, metastatic cancer or leukemia is going to trump lung cancer, lymphoma, colorectal cancer, breast cancer. So category 8, trumps 9, 10, 11, 12, category 9, 10, 11, 12, and so on. As you see with diabetes, diabetes with acute complications is going to trump chronic complications, or 19, which is diabetes uncomplicated. So let's look at this hierarchies with diabetes, very good example since we all have diabetic patients. You only get credit for one diagnosis within that HCC category. So all the complications, nephropathy, retinopathy, neuropathy, peripheral vascular disease, all of them code to HCC 18. However, you're only going to get credit for one. That doesn't mean you don't want to code them all, but you're only going to get credit for one. So it's important to understand that. And as I said, each one of these HCCs are grouped into condition categories, and diabetes being one, so has 3 of them. HCC 17, which is diabetes with acute complications, HCC 18, which is chronic complications, then HCC 19, which is no complications. 17 overrides 18, 17 overrides 18 and 19, 18 overrides 19. And that's what this demonstrates below here. Just to show you, and I'm going to use this throughout the presentation, this is a calculator that's online. It's using 2016, but it gives you the point here that basically if I entered these 8 diabetes diagnoses for this one patient that was born in 1945 as a male, they're going to get their demographic risk factor, which is 0.356. Remember, it doesn't matter what condition they have for that, but they're only going to get credit for one of these diabetes diagnoses, which 17 is the lowest, so they get credit for that. It just happens to be the same score as any of the ones with chronic complications. So basically, all of these other ones are overridden. The only thing they get out of this is a 0.368 with all 8 of those diagnoses, and then the demographics on top of that. So this is why it's critical for these MA plans that proper ICD-10 coding is done, because the RAF score determines their reimbursement, and without proper documentation, they need that to be able to continue this reimbursement, and we'll talk about documentation here. So RAF scores, each year they try and make the average RAF score as 1. This is approximately $9,100. For every 1% higher, I mean the CMS reimburses 1% higher for every 0.01 RAF increase. So if you go up, so a RAF of 2 is going to get 100% more than a RAF of 1, and so on. Each year they do this normalization factor, and that's to keep the average risk score at 1.0. So depending on what is coded and how the population ages or the population gets more sick or less sick, there is a normalization factor. In this, for 2017, it's 0.998. So basically, all the risk scores decreased somewhat over the year previous. And then there's a big difference between MA coding and fee-for-service coding, because in MA coding you have all the incentives for the MA plans to make sure that you're coding correctly, where in fee-for-service really nobody is overlooking your shoulder. That adjustment was 5.66 this year. Here's the way the average risk scores have gone over the past couple of years, and you can see 2015-16 we've pretty much seen an explosion because of new EMR technology, the incentives from MIPS, MACRA, MSSP, value-based coding. Now that everybody is coding correctly, you're going to see these average risk scores go up a bit. And this just shows that. So what happens when the average risk score goes up, that means overall some of the risk scores have to be adjusted, especially as that disease prevalence increases. So for example, diabetes without complications, 2011 was 0.162, now it's 0.104. With complications, 0.339, now it's 3.318, and you can see HIV dropped from 0.945 to 0.312. And that's what happens as we code better or the patients get more sick. Again, they have to adjust it so it comes back to that average risk score of 1. This shows you each category, what its value is. So if you have a diagnosis within those categories, like we showed with diabetes here, in acute you got a 0.368. However, in 2017, that's dropped down to 0.318. And again, I'll show you the diabetes thing here. So there's been, even though these are very small changes, because there's so many people with diabetes, the cost change is dramatic. So when you look at this risk score trend going up, we're seeing one of the major drivers is diabetes being up 20%. We're seeing the diabetes with complications way up, the HCC 18. We're seeing the HCC 19 down. So that means either more people are developing complications, or we're not coding very accurately, as most of us just coded diabetes before because there was no incentive. So now we're coding better. And then major depressions up 9%. Metastatic cancer, rheumatoid arthritis, morbid obesity. Of course, now we're all calculating the BMIs and putting those on the code. So again, I'm not sure if the population is getting fatter or we're just kind of coding better, and same thing with vascular disease. Documentation, critical. You have to have 3 different points. Diagnosis has to be face-to-face. Status, you have to say what the status is, stable condition, worsening labs or test order, and then a plan of action, COPD stable, continue current medicine. So those 3 points have to be in the diagnosis to have the diagnosis count towards a RAF and be able to put it on the super bill. We use this acronym MEET. If you don't have the MEET, you won't pass a CMS audit. So what is MEET? MEET is 4 different things. Monitor, signs, symptoms, disease progression, disease regression. Evaluation, document reviewing test results, medication effectiveness, response to treatment. Assess and address, order tests, discuss, review records, counseling, and then treatment, medications, therapies, and other modalities. So to make sure that diagnosis passes, if CMS is to audit your charts, you have to make sure you have documentation for each of these categories. Specificity is always the best choice. However, you'll see there's a couple of diagnoses where specificity does not apply, but history of indicates the condition no longer exists. You don't want to put that on your chart. So you got to be very careful of that, especially if they're chronic conditions that they're receiving current treatment. So history of diabetes, not good. Patient with diabetes since 2009, that's acceptable. History of CHF, meds, Lasix, no. Compensated CHF, stable on Lasix. History of COPD, no. COPD controlled with Advir. It's also, the documentation has to support the diagnosis. And if you pick the wrong diagnosis, you may not get an HCC RAF score. So when you pick an unspecified diagnosis like hepatitis C, you're not going to get any RAF score. When you pick an acute hepatitis C, you still don't get a RAF score. But chronic hepatitis C, of course, gets a RAF score in the HCC 2.9. Do not code non-definitive conditions. Probable, possible, questionable, rule out, those should not be on your super bill. Code the condition to the highest degree of specificity, signs, symptoms, abnormal test results, other reasons for the visit. If it's not documented in the medical record, then it did not happen. Beware of EMRs that automatically add previous ICD-10 codes to super bills. Those codes can't go on your super bill unless you've put the MEET or you've had documentation to show that you've accessed those, treated them, and you're monitoring them. Very important. So, summary of documentation, you must evaluate each diagnosis on the progress note. It must be face-to-face. You cannot refer to the problem list as documentation. So here's some examples of what you can use: the diabetes with neuropathy, stable, meds adjusted, hypertension uncontrolled, add medication. So diagnosis, even if it's listed on the progress note without an evaluation or assessment, is considered a problem list. You can, and does not provide the correct documentation. Every January, the slate is wiped clean. Patients that have 15 diagnoses have 0 as of January. So the amputations grow back, the COPD patients, the lungs get healthy, the diabetic patients have a pancreas that works like a charm, all kidney function is flawless. You get the picture. If you don't document the condition, you lose. So at the beginning of the year, it's important to remember these things: the amputations, limb amputations, ostomies, hemiquadriplegia, transplant status, HIV. Those are things that are recurrent and not going away, and you need to document each year. You have to watch the linkage. Okay, it's acceptable to use due to, because of, or related to. Not acceptable to use the word with, except for diabetes. So that's critical. Due to, because of, related to. Those are great. Don't use with unless it's with diabetes. Brief thing here on interactions. There are certain diagnoses that interact with each other, and these give you not only the risk score for the condition, but they give you an additional risk score. So as you can see here, CHF has a 0.323 risk score, diabetes chronic has 0.318, but when both of them are in the same patient, you get an interaction of CHF and diabetes, you get an additional 1.54. Here are some of the interactions: immune disorders with cancer, 0.893, CHF with diabetes, an additional 0.154, like we just showed, CHF with COPD, 0.19, CHF with renal failure, 0.27, cardiorespiratory failure with COPD, that's a 0.336, and CHF with certain heart arrhythmias is 0.105. So if they have a diagnosis from each of these categories, you'll get an additional RAF value from these interactions. Now, it's critical to understand there is a big difference between Parts A and B, Part C, Medicare, and Part D. Part D is pharmacy. So let's just look at that for a second here. We got a 72-year-old with active documented hypothyroidism, hypertension, high cholesterol, dementia, migraines, asthma, GERD, chronic stenosis. She's got a lot of different things going on, a lot of different medication interactions, a lot of things can possibly be going on. However, when we look at that patient's risk score, we see we get 0 credit for any of those diagnosis codes in the chronic condition category, the medical condition categories. We get the demographics, the 0.356, but that's it. Now, some of you, that may seem unfair, but that's the way they do that. However, why do we want to document all these conditions? Well, because there's a Part D or RX HCC, prescription HCC, a completely separate categories that give you risk scores for certain diseases now that require medications. So each one of these, hypothyroidism, panic disorder, high cholesterol, generalized anxiety, all the way down, migraine, glaucoma, Crohn's stenosis, cerebrovascular disease, asthma, GERD, osteoporosis, none of those have a risk score under the chronic medical conditions, but they all have risk scores under the Part D prescription plan. So as you look here, again, you get a baseline risk score no matter what, if you're on any medicine, so I'll just be based on your age. And then you're going to start getting a risk score for conditions like HIV. You're going to get a 2.93, opportunistic infections, 0.221. So it's extremely important. Diabetes, 0.396, thyroid, 0.095. So it's extremely important to include every diagnosis you're treating, because even though it may not RAF, it may RAF for drugs, and in a lot of your new incentive plans, especially with the Medicare Advantage plans, that's going to be critical. So you need to understand the difference. So there'll be two separate risk scores, a risk score for your medical and then a risk score for your drugs. Let's start with diabetes here just kind of quick, and we'll go through some different disease states. Complications of diabetes are the most frequently admitted ones. I think 75% of seniors have shown now that we have some sort of complications from diabetes. That's why I showed you previously where the diabetes without complications is decreasing and complications is increasing. So if they're only diabetes written in the progress note, then the correct code is uncomplicated diabetes, E11.9, the RAF is 0.104. Status of diabetes is critical to document. Poorly controlled or poor control is vague. You want to use uncontrolled or controlled, and that's the critical nomenclature. Controlled or uncontrolled, not poorly controlled or poor control. So quality documentation of diabetes, type 1 or type 2, you want to document is there manifestation or complication. Then you want to identify the systems. Like I say, 75% have the systemic complications. You want to name the manifestations in the system and state the manifestations is due to diabetes. Make sure you do that. You can't just list they have peripheral neuropathy and diabetes. They have retinopathy and diabetes. You have to say retinopathy is due to diabetes. And then you want to say if it's controlled or uncontrolled. These show you the different weights. Again, if you have no complications, your weight is 0.104, but any of the other ones are 0.318. Let's just look at this type 2 diabetic, has a chronic left heel pressure ulcer. We say in the history now, it's very important, the ulcer is secondary to diabetes, the peripheral neuropathy, and hemoglobin A1C is 9.2. Shows weak pedal pulses with purple cold toes and poor capillary reflow. So how are we going to code that? Well, we've got peripheral vascular disease, we've got a diabetic neuropathy, and we've got a pressure ulcer. All of those risk adjust. But you can, if you want, you can include the diabetes with the neuropathy, you can include the diabetes with the peripheral vascular, you can include both those diagnoses, but you're also going to get an additional code for the diabetic neuropathy and the pressure ulcer. Chronic kidney disease, this is a common one. Previous to a couple years ago, all these stages risk adjusted, but now it has to be stage 4 or greater to get a risk adjustment, and as you can see, that's a GFR of 29 or less, and then if you're in stage 5, it's 15 or less. But all of those 3, 4, and 5 in end-stage renal disease, of course, all risk adjust. Cardiology, you have to be very specific here. You can't use coronary disease, you can't use atherosclerotic heart disease. There's no RAF for that. So if they have angina, treated or untreated, it doesn't matter with pharmacological treatment or interventional cardiology, that's when you want to document it. However, if the angina resolves with the PCA or CABG and there's no pharmaceutical prescription prescribed, then you can't code angina. Coding of acute MI, it's only for 4 weeks after the diagnosis. So every visit in those first 4 weeks is coded as I2 2.9. However, after 4 weeks, it's not, and there's no continual anginal symptoms, then you have to use recent, old, or history of MI, I25.2. Remember, if they still have some angina, you want to code that angina. So the rule is acute becomes old in an MI after 4 weeks. Again, these show the difference between coding angina versus chronic ischemic heart disease, which gives you no RAF score. Even if it's asymptomatic but they're on pharmacological treatment, you still can continue to code angina. So if you've treated them with nitro or something for their angina, that's considered an ongoing treatment. CHF and cardiovascular conditions, again, you want to document and code chronic conditions such as AFib or arrhythmias, whether they're symptomatic or asymptomatic. As long as they need pharmacological treatment or other interventional cardiology, they're ongoing. Congestive heart failure is always chronic after the diagnosis. After it's diagnosed, it should be documented, coded, and treated as such. And again, this shows you the different HCC weights for CHF. You can get more specific with systolic heart failure, diastolic heart failure, left heart failure, pulmonary hypertension. You can use any of those codes, but they're all going to code to the same HCC risk category, so they're all going to be 0.323. Arrhythmias, rule. Once an arrhythmia, always an arrhythmia, unless it's permanently corrected without ongoing pharmacologic or mechanistic intervention. So remember that. Once you have the arrhythmia, it's always an arrhythmia. So AFib, aflutter, all of these are going to code to the same risk category. So it's, but you want to code all of them if they've had multiple ones, but you want to make sure you at least have one of them in every year. BFib, I think probably you should get more credit for that. That's not one of the diagnosis codes you really want to have on your chart, but you only get a little bit of a bump in your HCC weight there. Vascular, this is one that's overlooked a lot. Aneurysm, definitely get credit for, but aortic atherosclerosis, you get the same credit as whether you have the aneurysm or not. And same thing with atherosclerosis of the extremities. You don't get credit for atherosclerosis of the heart unless, again, you're having angina or some other complication. And peripheral vascular disease, the same. So, in cardiology, risk conditions that don't risk adjust, hypertension does not risk adjust, but it does, remember, risk adjust for the drug, so you always want to include it, but the condition that does give you a RAF score is the hypertensive heart disease malignant with heart failure. Coronary atherosclerosis, I said, doesn't risk adjust, but angina does. Atherosclerosis by itself doesn't adjust, but the extremities for peripheral vascular disease, atherosclerosis will. Chest pain won't do it, but angina will. Dysarrhythmia definitely won't adjust. You have to be more specific, AFib. In pulmonary, we have kind of the similar things with COPD, chronic obstructive asthma, chronic bronchitis, simple chronic bronchitis. All are going to adjust to the same HCC weight. So you need at least, if they have these symptoms, you need at least one of these diagnoses on the chart each year. Major depression, this is a very difficult one, as a lot of people don't use the specific diagnosis codes here, and that gets them into trouble. But episodic mood disorders, the F32s, there's major depression. You have to document the characteristics of the mood disturbance, mania, depression, single or recurrent, and you have to use specific medical disorder terminology. So if you don't document specific descriptor terms such as major or recurrent, the code has to be F32.9. That has 0 HCC weight, so you make sure that you document major or recurrent if that's true for the patient you're treating. And just to show you this, again, we took this patient, we put in all of these different risk codes. Major depressive, single episode mild, single episode moderate, severe with psychotic features, partial remission, full remission. All of them would actually risk adjust, but of course you're only going to get credit for one. However, if you put in the F32.8 or F32.9, the other depressive episodes or major depressive disorder, single episode unspecified, you're getting 0. So you just threw out 0.33 by putting unspecified, by not putting in that last feature, mild, moderate, or severe, or in partial remission or full remission. So again, shows the major diseases in psychiatric illnesses there, the major depression, recurrent, single episode, in remission, bipolar. Of course, schizophrenia, much more complicated, gets a much higher risk score. Alcohol dependence, alcoholism, drug dependence, opioid dependence, all these dependence diagnoses. We overlook these a lot. And it's critical to understand that you can't, if patients have this, that you document this correctly, use the right diagnosis, because they have a fairly significant weight of 0.383. So if you use long-term opioid treatments, C code, you're never going to get a RAF. But if they're opioid dependent, you use F11.20 and you get a RAF score of 0.383. So what do you have to satisfy to be dependent? Well, you have to show a maladaptive pattern of substance use, leading to some clinical impairment or distress, and you have to have at least 3 of the following: tolerance, withdrawal, increased usage over a long period, desire or unsuccessful effort to cut down on use, excessive time spent in activities to abstain the substance, or continued use despite doctor advice that there's problems related with to substance abuse. So any of those three, if you document, you can document opioid dependence. Malnutrition, another one that's underreported, especially in cases with cancer, pancreatitis, liver disease, COPD, end-stage renal disease, celiac, depression, dementia. So malnutrition is diagnosed if your BMI is 17.9 or less and low albumin, or weight loss of 5% in 3 months or 10% in 6 months. These carry a fairly significant high weight, 0.545, mild malnutrition, 16 to 17.9, albumin less than 3.5, and then moderate malnutrition. All are going to code to the same risk score. Morbid obesity, critical now for every patient you see in Medicare that you document their BMI at least once a year, so we're picking these up more and more though. But morbid obesity greater than 40 definitely gets you a risk score of 0.273, so you want to make sure all those patients with morbid obesity are coded with that BMI. And if they have a BMI of over 35, but you can link it to something that causes sleep apnea, hypertension, hyperlipidemia, diabetes, basically saying that their obesity has caused those conditions, you also get an HCC weight. So you need to do that as long as their BMI is over 35. But for every patient in Medicare, you should be documenting their BMI. Coding of strokes. Strokes are an acute event and should only be coded when the patient's having the stroke in front of you. Otherwise, you have to code it as history of stroke, and you have to show if there's any late effects. That's where the risk score is, and we'll show you those. So if you have hemiplegia or other paralysis or monoplegia, anything that's a late effect from the stroke should be coded as a late effect and use the appropriate ICD-10 diagnosis code. Of course, other things in neurology that you want to code, seizures and epilepsy, if even if they're on medicine and they haven't had a seizure forever, as long as they're taking that medicine, you code it. Parkinson's, again, that's another one that you want to make sure you use the appropriate code G20 for. Oncology is a little bit complex because you have to make sure you only code until the patient has completed definitive treatment. And definitive treatment means surgery, chemo, radiation aimed at eradicating malignancy. So if you don't receive definitive treatment for their malignancy, then you can code that malignancy diagnosis continuously. For example, though, breast cancer, prostate cancer on adjunctive therapy, tamoxifen and lupron, are coded only as if they have active disease because they're being treated. So patients who have completed therapy can only be coded with a personal history of cancer diagnosis code, even if they're undergoing surveillance. So remember that. If they've been treated and they're even undergoing surveillance, they have to be treated as history of. And again, this just reemphasizes that when you're treating with tamoxifen or lupron or some other medicine in any kind of cancer, those are active diseases, even if they're taking them indefinitely. Those are considered active diseases. However, if they've been treated to their endpoint and now you're just surveillance, then you have to treat them as history of. One of the biggest pitfalls in oncology is metastatic disease has its own ICD-10 code and its own HCC payment group, and it trumps everything else. HCC 8, which is metastatic disease, overrides all the other cancers, 9, 10, 11, and 12. So this is a condition where you lack specificity, and if you lack specificity, where if you were more specific, like I said, if you start listing, they have lung cancer, liver cancer, brain cancer, from colon cancer, you list all those cancers, you're only going to get credit for one of them. But if you list metastatic, it gets rid of that and gives you a much higher score than you're going to get with listing all 4 of those, and I'll show you an example here. So let's look at this patient. They've got 6 different types of cancer here: breast cancer, thyroid, parietal lobe, broncho, lung cancer, colon cancer, prostate. All of those are overridden once you put in secondary malignancy. So any kind of MET completely overrides all of those other HCC categories, and now the risk score that you get is a 2.484. And again, just a simple thing: prostate cancer with malignant or with metastatic to the bone or something like that. If you just put in the secondary code of C79.9, you're going to put a score of 2.484 rather than just a malignant neoplasm of the prostate, which is only 0.154. So When specificity doesn't change the RAF score, secondary cancers, malnutrition, cirrhosis, hepatitis, rheumatoid arthritis, osteomyelitis, schizophrenia, epilepsy. So basically, AFib, A flutter, COPD, emphysema, heart failure, you don't have to be as specific. You just have to have the general diagnosis. When you do need to be the most specific is with diabetes, angina, pneumonia, renal failure, chronic kidney disease, precious ulcer. Those things you have to be very specific for because you're going to get additional risk coding by using the more specific as opposed to the ones up here where you're just going to get the same risk score no matter how you code it. Now, as we talked about, there are some payments to the plans, and I just wanted to go through this pretty quickly. If we just take no diagnosis reported for a patient that's dual eligible, Medicaid, Medicare, has a 68-year-old demographic risk score of 0.30, they're going to get a risk adjustment factor of 492. Well, the plan's going to get an average payment for all the patients they're taking care of, $814. But for this patient, they're only going to get a $401, which means in the coming year, they're not going to get credit for this patient with their diagnosis codes here, and we're going to show you that. So if this patient has diabetes and you forgot to add it on, what you would see then is that your risk score went up to 0.589. Now your base payment for this patient is still below the 814 because the risk score is still below the average for the patients you're taking care of, but at least you've seen a change of about $78 per month, which over is almost $1,000, like we're showing down here. However, if you put all the diagnoses in, the type 2 diabetes with congestive heart failure, and you get the interaction code, now you get a risk adjustment factor. Again, please realize these values, this is an example we're using previous year's codes, but I'm just doing this for example purposes. Now you're going to see the PMPM for this patient go up to 1138. Now you're up to $13,656 that you're going to be paid for this patient next year, as opposed to where you started at, $4,800. So you can see just by adding those two codes, you're going to get reimbursed $9,000 more for taking care of those patients. A little bit of a case study here. You can kind of read this, a wellness visit, which is a great place to document all these things. You document the history of diabetes, neuropathy, and major depression, and then you look at the medical history of diabetes, neuropathy, congestive heart failure, toe amputation. You see a BMI of 42.5 here, decreased sensation, so you got some peripheral neuropathy. So basically their assessment was medical screening, preventive care discussed, diabetes stable, continue current treatment plan, neuropathy stable, continue current treatment plan, major depression stable, current treatment plan. So let's look at the difference of how they documented it. They've got to document he's a 66-year-old male, so he's going to get a risk factor for that. Medical screening, you're not going to get any risk factor for that. Diabetes uncomplicated, because if they didn't say that the neuropathy was from the diabetes, they only get a 0.118, whereas in the neuropathy, they get the 0.368. So they documented as diabetes uncomplicated and neuropathy, which basically they missed out about 0.25, 0.26 there in their risk. Major depression, again, they used the nonspecific, the F32.9, as opposed to using the major depression mild, which gave them a score of 0.330. Obesity, they didn't put the morbid, but however, they did record the BMI, which is required, so they do get credit for that 0.365. And then, of course, you don't get credit for both. You only get credit for one. The great toe amputation, of course, you're going to get credit for that in both of these, but they didn't mention the CHF. By not mentioning the CHF, not only did they lose the 0.368, but they lost the interaction there. So just by adding those two, they're changing things a little bit around. The neuropathy, the depression, and the congestive heart failure, they went from a risk score of 1.55 to a risk score of 2.68, which is fairly significant. Now, just going to show you finish with some examples here. I want to show you this patient that has 9 different diseases here, each one of them in a different category of HCCs. None of them override, so their risk factor total was 4.132. Of course, they're born in 45 as a male. They get a demographic risk factor of 0.356, but they get the interactions here, CHF and COPD, CHF and renal, and diabetes and CHF. As you can see, that added almost 0.8, a little more than 0.8 in risk score, which is significant. Now, you can only get credit for one of the 18s, no matter how many diagnoses you put in here. So a couple of things I wanted to point out in this slide. I apologize, this kind of overwrote, but if you can see here, we put in 2 different diagnoses with diabetes, but the one was overridden, so you're only getting credit for the 0.368. The other thing is people get hung up on the fact of, remember, HCC its diagnosis is code to different HCC categories, but it doesn't matter what the letter is. Some people think you're only getting credit for one I letter. Well, if you look here, ventricular tachycardia, pulmonary hypertension, atherosclerosis all begin with I, but all give you a risk score. So do not judge it by the ICD-10 letter. That's not what determines the category. The categories are determined by the condition. So I want to show a couple examples of where, if you just change things around a little bit, what can happen. Well, this patient had gangrene, and they forgot to list it. So we put gangrene in. We get a 1.43 for that. However, now what gangrene does is it trumps our atherosclerosis of the aorta and our acquired absence of the left leg, or BKA. So basically, we gain the 1.413 with the gangrene, but then we lost 0.229 and 0.779. But overall, by adding the gangrene, we actually increased the risk score by 0.405. Now, if we remove the gangrene, because we had an ulcer, we lose that 1.413, but now we gain back the BKA and the atherosclerosis of the aorta, and we get 0.536 for the ulcer. So overall, in this scenario, we gain 0.2. Now, what if we include all of these things? So there's only room for 10 diagnoses in this system, so I have to add back the bipolar, which is 0.33. It's not on here, but that you have to add that back. So we put the gangrene in. Now we lose credit for our ulcer, we lose credit for our atherosclerosis of the aorta, and we lose credit for our BKA. However, still our overall gain is 0.129. So what the moral there is, put all of these codes in no matter what, and it's most likely going to improve your RAF score. Again, showing here that back to the cancer, if they have 4 or 5 different kinds of cancer, but you're not sure if any of them are metastatic, like I say, that's why it's critical. If you know they're metastatic, you got to code metastatic, but if not, it's going to take the lowest category, which in this one is lung, and give you the highest risk score, and all the other cancers aren't going to matter. So even if you have a patient with multiple single primary cancers, they're not going to give them credit for it. They're only going to give them credit for the most significant one. The last thing I want to go over is the CMS audit process, because if you do anything with Medicare Advantage, they do these audits. These audits verify your diagnosis codes, and they're selected at random. And you as a provider are subject to helping these audits. So if you haven't documented it, and you've coded it, then you've actually kind of given the MA plan some misleading information, and they can get fined for that. So that's why it's imperative that you follow those documentation guidelines. So if you forget to add the meat, this can be considered deceit, which means CMS can turn up the heat. Not to end with such a corny thing, but basically it's critical that you document these conditions, especially now in the technology we have with these AMRs where they automatically put this stuff in. Make sure you document it, make sure you assess it, make sure you treat it, make sure you have everything you need. I hope this was helpful, and if you have any other questions about this, you can always email me or give me a call. I appreciate it, and hope you all have a good day.